Thank you very much, Dr. Ahmed Al for this very fruitful presentation. Thank you very much. I think the discussion, we will save it for a while and go to the next presentation.
Now we listen to Dr. Ali Fadil, consultant pediatric cardiac surgery from الثورة Hospital, the entitled Under Our Experience in Pulmonary Artery Banding.
السلام عليكم ورحمة الله وبركاته. نحن نشعر بأنكم قد أنتم مرهقين وإحنا أيضا مرهقين زيكم، وبالتالي استحملوا باقي القليل إن شاء الله. My talk about our surgical experience in pulmonary artery banding. I will speak about this, my agenda. The pulmonary artery banding is surgical artificial narrowing in the middle of pulmonary artery trunk to reduce pulmonary blood flow and pressure. It is palliative procedure performed in infant and young children with congenital heart defect until definitive corrective surgery can be performed. The first description of pulmonary artery banding in the literature was reported by Miller and Duman at the University of California, Los Angeles in 1951 when they did pulmonary artery banding for the baby 5 months with large ventricular septal defect. This structure important for the cardiosurgery. We make here pulmonary artery band the mid for pulmonary artery, and this side, the medial ascending of the aorta, and this left atrium, and we have here coronary artery. Indication for pulmonary artery banding, pulmonary hypertension, heart failure, failure of medical management, protect pulmonary vasculature. Indication for surgery, the banding is primarily indicated for congenital heart defect, the first group with left to right shunt lesion like ventricular septal defect and arterioventricular septal defect and truncus arteriosus. The second group with double outlet right ventricle, transposition of great arteries with large ventricular septal defect, and others with complex single ventricle. We have contraindication. We have divided to two categories. This is important for cardiosurgeon performed this pulmonary artery banding must be known what about contraindication. Absolute contraindication, severe pulmonary hypertension when the blood pressure in pulmonary artery and systemic pressure in the same level, or Eisenmenger syndrome. Left ventricle outlet tract obstruction, severe left ventricle dysfunction, anatomical abnormalities, precluding band placement in the pulmonary artery. Palliative procedure, implants ventricular function, complex intracardiac anatomy, significant left ventricle outlet tract obstruction, hypoplastic or dysfunction left ventricle, and large arterial septal defect. The typically performed the infant pulmonary artery banding under 6 months of age with significant pulmonary over circulation and symptoms, and others with perioperative stabilization patient from acute heart failure or other systemic illness before underlying elective pulmonary artery banding. We have 3 stands for surgical approach for pulmonary artery. The first one with the mediastinum, and the second with anterior left thoracotomia in the third of the second or the third of interspace, and others, and the third left lateral thoracotomy. Steps of pulmonary artery banding, we started with mediastinectomia or left thoracotomia for access, then placement of band around the main pulmonary artery, adjustment of band to achieve the desired pressure gradient. This my patient with mediastinum. You can see after we opened pericardium, we found the large main pulmonary artery compared with the ascending of the aorta, this systemic proliferation with suturation. After we make pulmonary artery banding, we check blood pressure post-banding in this area. This 31/14 and saturation. This in the after 6 months patient in ICU with good condition. Others patient with left thoracotomy with patient large ventricle septal defect and patent ductus arteriosus. We started to make ligation of patent ductus arteriosus, this systemic blood pressure. After banding, this blood pressure in post bandage, this in ICU patient, this patient came for OPD with good condition. Why to make for pulmonary artery banding? To decrease pulmonary artery blood flow and pressure, prevent pulmonary artery hypertension, preserve pulmonary vascular resistance, and buy time the implant to grow before preventive surgery. Post-operative management. All patients post-pulmonary artery banding must be required monitoring for systemic blood pressure, pulmonary artery pressure, oxygen saturation levels, and heart function. Post-operative complication, banding migration, right ventricle hypertrophy and dysfunction due to the tight of pulmonary artery through the banding and residual pulmonary hypertension, arrhythmia, growth-related complication, and bleeding. Our results depending on the age and condition of patient at the time of surgery and dependent also on the skill of the surgical team and also the severity of the underlying heart function. Mortality, recent studies are refused suggestive preoperative mortality rate of congenital heart defect with severe pulmonary hypertension range between 5 to 25%. Post-operative mortality rate in elective pulmonary artery banding from 2 to 5%. Cause of mortality, severe preoperative condition, inadequate band adjustment, post-operative complication, and complex congenital heart disease. Our experience in pulmonary artery banding, the aim of this study to present our experience with pulmonary artery banding in patients with congenital heart defect with excessive pulmonary blood flow and severe pulmonary hypertension. In clinical study, all 41 patients who underwent pulmonary artery banding between 2019 and November 2024. All patients underwent complete cardiac ovulation, CT angio, including physical examination, ECG, and chest X-ray. And all patients signs consent obtained before their parents. The patient received general anesthesia and during and intubation during the procedure. This slide, you see this almost of our patients, about 70% in female. And this slide, our patient less than 3 months, about 53%. And by weight, less than 40 kilogram, about 68%. The case is divided by type of congenital heart disease with complete AV canal defect, ventricle septal defect, and BDA, patent ductus arteriosus, ventricle septal defect, and patent ductus arteriosus, and ventricle septal defect. Deficient by severe pulmonary hypertension. You can see almost of our patients with severe pulmonary hypertension. The time extubation, post our procedure extubated about 90% during 6 hours after operation. The time in ICU patient, about at least 3 days, about 78%. And we have complication, 2 cases with tight pulmonary artery banding and 2 cases with valves and 1 case migration pulmonary artery band. Follow-up before discharge, we make for patient with physical examination, ECG, radiogram, and echocardiography. Discharge our patient from our center almost of our patient discharge in 8 days, about 90%. The results of our surgical management of pulmonary artery banding in 41 patients, the procedure provided successful in 85.37%, 1 patient with band migration, 2 patients with Walls band, and 3 patients in death. In conclusion, pulmonary artery banding is temporary isolation of management of congenital heart defect with excessive pulmonary blood flow. Pulmonary artery banding is ineffective and preventing pulmonary vascular disease and preventing irreversible pulmonary hypertension. Pulmonary artery banding is preventing right ventricle overload and improve cardiac function. It requires careful planning for future corrective surgery, and results of pulmonary artery depends on many variations like age, condition of the patient at the time of surgery, and type of congenital heart defect, and the scale of surgery team. Thank you for your attention.